You wake up feeling completely fine, perfectly normal strength. But by the time you finished brushing your hair or eating breakfast, your muscles simply refuse to work. It's this sudden, severe, and bizarrely fatigable weakness. Welcome to this explainer on Myasthenia gravis, where we're going to unravel a fascinating medical detective story behind this incredibly complex condition.
To solve this mystery together, here's our roadmap for today. We'll start with an introduction to myasthenia gravis, head inside the neuromuscular junction, talk about recognizing the symptoms, diagnosing the condition, and finally wrap up with treatment and prognosis. Let's get into it.
Section 1. Introduction to myasthenia gravis and taking a look at who it primarily affects.
So, myasthenia gravis. It's defined as the most common autoimmune neuromuscular junction disorder out there. But honestly, the absolute key word you've got to focus on here is fatigable. We're not just talking about your standard end-of-the-day tiredness. No, this is an acutely evolving, fatigable skeletal muscle weakness. What that means is the weakness actively worsens the more you use the muscle throughout the day, and then it miraculously improves with rest. It's the absolute hallmark clue of this disease, and it tells us something very specific is happening right down at the muscle level.
And this brilliantly illustrates who we're talking about. Notice the distinct bimodal peak incidence. It primarily strikes young women, we're talking a peak between 20 and 40 years old, and then it also hits older men, usually peaking between 40 and 70. Overall, women are affected slightly more often than men, maybe at a 3-to-2 ratio. Let's keep these demographics in the back of our minds as we hunt for the underlying mechanism.
All right, Section 2. Inside the neuromuscular junction, the microscopic scene of the crime. Now, what's really interesting about how this works is exactly where the breakdown happens. Under normal circumstances, your motor neuron releases these tiny packets of a neurotransmitter called acetylcholine. They float across the gap, bind to the receptors on the muscle membrane, and boom, you get a healthy muscle contraction. But in myasthenia gravis, rogue autoantibodies totally hijack the system. In about 80% of cases, these autoantibodies are directly targeting and attacking those postsynaptic acetylcholine receptors. Let's look at how this sabotage actually builds into total muscle failure. There's a three-pronged attack happening here at the receptors. First up, we have competitive blockade. The antibody just selfishly sits on the receptors so the acetylcholine physically cannot bind to it. Simple, but devastating. Second, receptor internalization. The antibodies literally cross-link the receptors together, causing the muscle cell to basically swallow them up and degrade them, so far fewer receptors are even available on the surface to begin with. And third is complement activation. The antibodies trigger an immune cascade that literally blows holes in the muscle cell membrane. It leads to cell lysis and massive damage. The end result of all three of these mechanisms? Impaired signal transduction and practically zero muscle activation.
Moving on to Section 3. Recognizing the symptoms and looking for those clinical clues.
Can you imagine the sheer frustration of your body just failing you from doing something as basic as looking up or chewing your dinner? Eye muscle involvement is actually the most common initial symptom we see in generalized disease. Patients often experience ptosis, that's a severely drooping eyelid, or diplopia, which is double vision. From there, the weakness can spread to the bulbar muscles, making it incredibly hard to swallow or speak clearly. Eventually, it hits the proximal limb muscles. A simple everyday task like standing up from a chair or brushing your hair suddenly turns into this monumental, exhausting effort. To confirm those ocular symptoms right at the bedside, medical detectives use some really fascinating, highly specific physical exam clues. First up is the ice pack test. Get this, if a patient has a drooping eyelid, applying an ice pack to it for just 5 minutes will actually improve the ptosis by 2 millimeters or more. Why? Because the cold temperature naturally slows down the enzyme that breaks down acetylcholine in the synaptic cleft. It's brilliant. Then there's the curtain sign. If you manually lift the patient's more severely drooping eyelid, the brain stops trying so hard to keep the eyes open, and the other eyelid suddenly drops just like a curtain. It's a highly specific, interactive, real-time demonstration of the disease's underlying mechanics. Section 4. Diagnosing the condition. Time to run the lab tests and imaging.
Okay, so one of the absolutely most critical steps in diagnosis is checking the thymus gland. There is a massive clinical connection here. A staggering 65% of patients with myasthenia gravis have thymic hyperplasia, an enlarged overactive thymus, and another 10 to 15% actually have a thyoma, which is a tumor of the thymus gland. Because the thymus plays such a central role in training your immune system, its malfunction is deeply tied to the production of those rogue autoantibodies. And that is exactly why a chest CT scan is an absolute must for every single patient confirmed to have MG.
Of course, we also run specialized blood tests to catch the culprit antibodies red-handed.
The initial test looks for anti-acetylcholine receptor antibodies. If they're present, we classify it as seropositive MG, which neatly accounts for 80 to 90% of generalized cases. But here is a vital warning. 10 to 20% of cases are seronegative, meaning that primary diagnostic clue is completely missing from the blood, but the disease might still be lurking. In these seronegative patients, especially those who have prominent bulbar symptoms like trouble swallowing, we often find a totally different culprit: anti-MuSK antibodies. So a negative initial test doesn't automatically clear the suspect.
And finally, Section 5, Treatment and Prognosis. Let's crack this case.
So the crucial point here is that treating this requires a really delicate multi-pronged balance. Our first-line therapy is pyridostigmine. It's a cholinesterase inhibitor that basically stops the breakdown of acetylcholine, maximizing its activity at whatever receptors are left to give the muscles more strength. If that's not enough, we step up to immunosuppressants like high-dose prednisone to stop the body from producing the attacking antibodies in the first place. But equally important are the contraindications. There are things we absolutely must avoid, like certain common antibiotics such as fluoroquinolones and macrolides, or muscle relaxants, because they can severely worsen that muscle weakness. We have to be incredibly careful.
And speaking of worsening weakness, if a patient's respiratory muscles fail, they enter what is called a myasthenic crisis. This is a terrifying, life-threatening emergency. Up to 60 to 90% of these patients are going to require intubation and mechanical ventilation just to breathe. To rescue them, we've got to pull out the heavy hitters: intravenous immunoglobulin, which quickly lowers the production of autoantibodies, or plasma exchange, which literally filters the destructive antibodies right out of the patient's blood for a really rapid, marked improvement.
The good news? Overall, for many patients, especially those with purely ocular disease or young women who undergo a surgical thymectomy, the prognosis can actually be excellent. But it leaves us with a lingering provocative thought. As we continue to perfectly map out the exact molecular sabotage of these autoantibodies, what could the next breakthrough in highly targeted autoimmune therapy look like for these patients? It's a fascinating frontier. Well, I want to sincerely thank you for joining me today on this investigation. Keep learning, keep asking great questions, and thanks so much for watching Mid-Medicine.